I'd like to thank the organizers for inviting me to come here today. It may be sad, but databases have become my passion, and I'm really excited about sharing this with you. So I started with this project right after we initiated our multidisciplinary ALS clinic in 1997. I needed a way to send letters out to all of my patients. As a nurse with no administrative or secretarial background, I had never heard of a mail merge. Somebody told me what it was. Sounded like a great idea, and before I set my mail merge up in Excel, a doctor that I work with suggested that I explore using an Access database instead of Excel, explaining to me that it was much more powerful. I'm always interested in becoming more powerful, so I gave it a try. After I got my mail merge set up and my database set up, I started recognizing that there were other things that I could do in this database besides keep a table of my names and addresses. When we started our clinic and we had a small number of patients and they began their first return visits and then their second return visits, we found out that it was useful for us to have a pen and paper flow sheet in the front of each chart so that we could write down the date of the visit, what the weight was, what the vital capacity was, and so on, so that when we saw the patient on return visits, we could very easily see where they were and where they had been. So it was logical, let me move this type of data into my database. We also added clinical milestones, so at a glance we could see when the onset of symptoms were, when the diagnosis was made, and other milestone type events like that. But the best thing for me is that it's right there on my desktop. I can look at it anytime I want and in a matter of moments ask questions and get answers. So what is a database? A database is simply an organized collection of data. Other examples of organized collections of data include an index card box, which is where I started, a filing cabinet, flow sheets, and spreadsheets. But there is specific database software that is much more powerful than an index card box. And we use Microsoft Access because the Microsoft Office package is on all of our computers at our institution. But there are others that are just as good, and perhaps some are even easier to use than Access is. There are certain components that are part of every database, and the first component, the core, is the table. The table is the repository of the data, and it looks very much like an Excel spreadsheet. It has columns and rows. It doesn't do calculations very easily, which Excel does, but it does a lot of other things in terms of managing and modifying your data to make it easy to use. The second component of the database is the query, and the query is what you use to ask questions of your data. So for example, if I'm at my desk and somebody says they want to start a support group of women between the age 30 and 50, I can very easily go into my database and generate a list of active patients that are active women who are between that age group and come up with something that we can work with very easily. The next useful item is called a form, and a form is something that sits on top of the table, and all it does is make data entry a little bit simpler and a little bit more prone to accuracy. Access is very unforgiving. Once you make a keystroke, it's automatically saved. So if you make a keystroke in a box that had other text there to begin with and you've overwritten it, what was in the box before is gone. Therefore, having a form to do your data entry helps a little bit with accuracy and certainly makes it easier for the person doing the data entry. And lastly, the report. The report is what you can use to display your data, your query or your information in a meaningful way. Now I want to explain just a little bit about relationships within a database. The first relationship is the one-to-one relationships, and that's what I would see if I made an Excel spreadsheet. There's one name, one person with a first name, with a last name, with a date of birth, with a medical record number, and that person had their onset on this date and their feeding tube was inserted on this date. It's one patient and one set of data. The next is the one-to-many relationship, and that's what I have in my second table. There's one patient, but they've had multiple visits, and in each visit we collect a certain data. I don't use any many-to-many tables in my database. I'll just tell you that so you've heard the term before. And the many-to-many, an example of that would be if you have multiple patients who use a variety of different breathing support devices. So you could use the multiple or many breathing support devices in the many different patients and develop a many-to-many table. On my demographic table, I have two primary tables. The first is the demographic, and that is the one-to-one. It contains the patient identification and all of their other PHI, their insurance information, other things that we find useful in our clinic, which is their pharmacy telephone number, their milestones, whether or not they're familial or sporadic, whether or not we have done genetic testing, whether or not they're active and being followed at this time, or whether they're deceased, and another field, which I'll explain to you a bit later, which we call For Current Clinic. So this is my demographic table, and it's very big, and I assume you really can't see much of it. So I'll just mention that over here is a list of the other tables that are in the database. Over here are the list of the forms that are in the database. And then this is the actual demographic table. But I've blown it up so you can see it more easily, and you can see that the last name is here, first name, an auto number, which the system generates for me, their medical record number, date of birth, gender, race, ethnicity, and so on. So on this table, in these lines, are all of those things that a patient would experience or have information about that's one time. Make note of this little X over here, and I'll tell you a little bit more about that in a few minutes. The second table is our clinical table, and this is where we keep all of the events that happen to a single patient on multiple time points. So we connect it all together by the medical record number, and the date, of course, of their visit, and then these are the sorts of things that we collect during those visits and place in this table. Their weight, their vital capacity, the percent predicted, negative inspiratory force, whether or not they're taking Relutek, the date they had their PEG, whether or not we have discussed advanced directives with them, and if so, what their decision has been. If we can identify that they have an impaired cognitive status, which of our several physicians have seen them, and something that we call the phenotype. We have become interested in identifying certain phenotypes within patient groups, and as we identify them, we'll add them to the database so we can follow and see, is this something that we do see regular? For example, people who have diaphragmatic weakness without any bulbar involvement, and these are the people that you see that breathe with their accessory muscles. So we're now pointing out and saving information on patients with that particular phenotype. This is a picture of my clinical table, and it's the same thing. The table is listed over here. These are the other tables that I have. These are some queries that we've made up that and saved to use repeatedly. But blown up so you can see it a little bit better. And let me also point out, in case there are any HIPAA police in the audience, that all of this information has been changed with the names changed and all the dates of birth and everything changed to protect the innocent. This table is sorted by their medical record number, so it's in numerical order that way. You can sort it in any way you want. And so this is the second table connected to the first table by the medical record number. Now, remember I mentioned about that little X that you see over here? Because these are connected and because we had the ability to do so, we created a subtable which takes the information from the clinical form and matches it up with the demographic form. So when I'm at my desk and a patient calls me and they're having eating problems, I can open up my database and simply press on this button right over here, and I can see what their weight has been over time, what their vital capacity is, and their percent predicted, so I can have an intelligent conversation with somebody over the phone, having the information that I need very close at hand. From those two tables, we generate two reports that we print before each clinic and staple to our folders that we take into the patient room. This is the first one, the clinical data sheet. This is the top half of the same form blown up to make it a little easier to see. And this form pulls information from old records so that we can see that the previous date of visit is listed there. A little bit lower, we have the previous, from the last visit, their breathing numbers, their last ALS functional rating scale. And then at the visit, we will handwrite in the date of the visit, what their current weight is. If I notice that some of these are blank and we're missing when the date of symptom onset was, then I'll handwrite it in at this time in the clinic visit, and then we can complete that component of our data collection. We'll handwrite in the total functional rating scale over there and note if the patient is receiving services from hospice or if they're taking Relutek and so on. The bottom half of the sheet shows us what the patient's status is related to advanced directives and also feeding tube, so that if you walk in the room and the patient's in their street clothes and you can't remember if they've had a PEG or you can't remember if we've ever talked to them before, you can go back and look and see that you have talked to them and they already had their feeding tube and what the date of it that was placed in it makes you seem a little smarter. These are some of the phenotypes that we collect, as well as the physician that is seeing the patient at that particular visit. The second flow sheet we use is looks like this, and this is on one side. So the top data is this information that's the one-to-one. The top is the identification of the patient, their date of birth, what their height is, so that when we do their vital capacity testing, we're always going to get the same height each time. And then blown up, you can see what it looks like. So again, very easily, you can look and at a glance see exactly what their weight is over time. So how did I learn all this? And I started with Access for Dummies. I recommend the book because it's written in the language of somebody who isn't native to the jargon of computer speak, but it doesn't make you feel like a dummy. So I found that to be particularly useful to start with. On the other end of the spectrum is the Access Bible, and this is about 1,000 pages long and costs close to $100. And this book has the answer to anything you can imagine asking. This is truly the Bible. It has everything in it, and I haven't bought one yet. Or you can use online training, and this is something fairly new called lynda.com. With Lynda, you pay a monthly subscription fee that's pretty reasonable, and you can take any of the classes that is offered by Lynda. And they have access in the beginners, intermediates, and advanced, as well as practically any software program you can think of. You can learn yourself at your own pace on lynda.com. Another example of that self-learning is teachucomp.com, and I haven't personally used that. I believe that they specialize in the Microsoft products, but I've heard good things about it. So into the future, the next step for us is going to be mining the data. So if you take data from patients and you extract generalizable information and you publish it, that's called research. And you can't do research on human beings without going through an IRB to make sure your patients are being protected. So in the next year, I'm going to be submitting my database to our IRB to hopefully get permission to use this database for data mining. As new patients come in on their first visit, we'll ask them to sign the consent form once we get one approved. And patients who are deceased are not protected by IRB. Only living patients are protected by IRB. So all of the patients that have data in the database but have not signed a consent, they're in sort of a gray area. As much as possible, we'll ask them to sign consents on a later basis when they're come for return visits. But if they're not coming to clinic anymore, then my choices will be to reach out for them and try and get consent anyway, or to ask the IRB for a waiver and allow me to use their data without having consent from them. I don't know what they'll think about that. Another thing that I can see using this in the future for is data sharing. The Muscular Dystrophy Association has currently developed a large registry for patients of neuromuscular disorders, and they want patient data entered into it. We're already entering every single thing they're asking for in our own database. I can't imagine entering it into two different databases, but I believe that I can make a tool that will link the two so I can enter the data into my database and then upload it into the Muscular Dystrophy Association database. And the same goes for Neurobank, which is another large database registry of patients that's being developed by the Niels group, or has been developed, and I hope that in the future I'll be able to do a data transfer as well without having to do duplicate data entry. And I've also found that it's nice to use for long-term relationships, for families of deceased patients, to send them periodic personal notes and let them know about advances that have been made in the field, or progress that we're seeing at our center. Just as a way to let them know that we're still thinking about them and the contributions that their family member made by participating in whatever research they did is remembered and is still important. One last thing I want to say, and that is if you have the opportunity to have somebody professional come in and make a database for you, that's sweet. And if I had had that opportunity, I certainly would have taken it. But there's a lot to be gained from developing it yourself, from learning the skills and developing it yourself. If you have somebody else write it professionally, it will look much, much nicer, more pretty than my database does. But if you have a problem, you can't fix it yourself. If it gets out of sync somehow. You can't fix it yourself. Mine, I can fix it myself. So I urge you to consider in that situation of either learning how to do it yourself or working very closely with the developer so that there isn't a problem that you can't fix yourself when you're using it. That's my colleagues that I recognize for all of their support, including in maintaining my database. And that's when the Atlanta Falcons were having a better year.
Thank you, Meraida. Okay, we've time for some questions, but perhaps I can kick off. Could you explain IRB?
The Institutional Review Board is responsible for patient protection for all research activities. And so they're the ones who approve our consent forms. And if a patient feels that they have not been treated properly in the research process, then the patient would reach out to the IRB for mediation.
Thank you. Okay, and questions from the floor? Okay, one over here. Laura?
I actually, my name's Lauren. I'm from the Philadelphia MDA ALS Center of Hope. And a database like this is something that our neurologist has also expressed a lot of interest in developing. In the spirit of data sharing, are you willing to share kind of your sample that you have? Okay, that's great. I would love to get your email and get a look at what you've done and something we could develop off of as well.
Okay, question at the back.
Does Emory have EMR?
Yes.
And so does this database that you conjured up, does it work with your EMR, or is two separate?
It's two separate things.
So can I just interrupt? Could you explain what EMR is?
Sorry, electronic medical records.
Thank you.
Which is, now everybody's putting all their information into that, and you can pull up for the system instead of using regular paper charts.
There are two primary electronic medical records used in the United States. The first is Epic, and the second is Cerner. We use Cerner. There are people within the ALS community that are working very closely with Epic, so that the data from Epic will be downloaded into something that you can use on your desktop, or so I've heard.
Yeah.
No such process has been started with Cerner,
Yeah,
although
we have
Cerner has been approached, and they say anything Epics can do, we can do better. But that process has not started.
No.
When I was told about the Epic thing, I said, it sounds to me like curing ALS. We all want to be there when it happens.
Right.
But I've been told by somebody who should know that in the next few months it's going to happen.
The
Thank you.
Cerner thing?
The
Final question?
Epic thing.
Okay, over at the side. Yeah.
Hi, hello? I'm over here.
Sorry.
So first I wanted to congratulate you on your initiative. It's very thorough. It looks like it's very nicely organized, and it's probably very helpful when you're trying to do patient management as well as research efforts. I was curious why you listed smell and taste as, quote, special senses.
Generally speaking, patients with ALS do not have impairment of their sensory. But one of our physicians noticed a few patients that did and wanted to track it.
Laid as a marker for frontotemporal disease?
I never thought about that. But we do collect cognitive impairment as well, so that would be a wonderful thing to correlate and look at.
Okay, thank you, Meraida, for such an interesting presentation there. Please.